of whenever there is taste of bitter, there is taste of sweet. Whenever there is suffering, there is remedies. Whenever there is phobic disorder, there is cognitive behavioral therapy.
You would like the time to be limited عشان كمان
Most probably 45 minutes.
Okay.
45 minutes.
Good.
To the 50s. Our topic today is cognitive behavioral therapy of phobic disorder. Just going quickly over some basic things. To start with the definition of phobic disorder, it is an irrational, persistent and excessive fear of an object or situation that is not in fact dangerous, or if it's dangerous, the fear is not appropriate to the degree of dangerousness. Phobias are disabling and not adaptive. The types of phobias, as all of us know, that it might be a simple phobia confined to single feared object or situation, or social phobias, fear of negative evaluation, rejection, criticism by others, which is appeared in the sort of speaking or eating or writing in public in front of other individuals. We have agoraphobia, that fear of entering crowded places, or fear of confined spaces, or of public transportation, or fear of being far from home. Regarding frequencies, many literature actually contradict each other regarding the frequencies of each type of phobia, but generally speaking, mild phobia affecting 1 in 9 adults, and it is common in early childhood till the age of 6 years. In adult population, ladies tend to be more than men in agoraphobia, but in social phobia, male and female equal in incidence. This is in America. I don't know, we ask Prof. Abdel if there is any difference in our population. Origin of the phobia. As a simple logic, it is possible to be phobic from any object or situation. But there is argument about this. They said, some authors said that the things feared may be or have once been potentially dangerous or threatening to the human being or human race. When we restrict ourselves in the cognitive behavioral model of anxiety and phobic disorder, the phobic is not afraid of the situation or object and of itself, but rather is afraid of the consequences of being in the situation or in contact with the object. The well-known behavioral model of phobia, that learned fears through direct conditioning or vicarious conditioning, that is when the fear is learned by observing the fear of other individuals. Or it might be transmission of information or instruction from other people. Fear usually builds up gradually as a result of repeated, more or less frightening experiences or through social learning. It is certainly not necessary to know the exact cause of the disorder to treat it successfully. No, we are dealing with symptoms, we are treating symptoms. Regarding symptoms and reaction to it, the model of phobic anxiety we have the original situational trigger here. It will cause either physiological, behavioral, or subjective meaning. Physiological, as you all know, heart thumping, palpitation, sweating, trembling, etc. Behavioral, things running away, freezing, shouting for help. Subjective feeling, for example, internal discussion in the person himself. I might fall, this is terrible, fear, embarrassment, etc. These will lead to symptoms. And ordinarily, the symptoms will abate with the stimulus is gone. But what happened here, is the fear exaggerated due to many reasons. If it's physiological, this is the basis of a biological model of the phobic disorder. If it's behavioral, this is the basis for behavioral approach to the phobic disorder. If it's subjective, and this is the area of work in cognitive therapy of these disorders. These symptoms, no harm from it. This is anybody can develop these symptoms. But if the reaction developed to these symptoms, this is the start of vicious circle in which the feared person or phobic patients get around and will suffer. It will appear also either in the physiological form or behavioral or subjective. The important things here, behavioral component of reaction. The important things is avoidance, because this factor will maintain and perpetuate the vicious circle in which the phobic patients cannot get out. Subjective reaction, I cannot hope, I must get out, lowered confidence, worries, frustration, fear, and this is, as I said, this is the area of work of cognitive therapy. Actually, the theoretical background of the cognitive behavioral therapy, behavioral mainly because it is the earlier one, goes back to the experimental psychology, mainly by Wolbe at 1958. The hypothesis was abnormal behavior, like normal behavior, is learned. When we know in normal psychology of normal individual, behavior is learned. So the fact or the hypothesis here that abnormal behavior is like normal behavior, it is learned. So what has been learned can be unlearned, and more adaptive behavior learned instead. This is a simple theoretical background of the cognitive behavioral therapy of phobic disorder. And treatment simply aims to graded exposure to break this vicious circle and prevent this avoidance, to face the real situation without the reaction which is happened in consequence to the symptoms. The guiding rule for exposure, this is just before going to the treatment and practice. Exposure facing something that have been avoided because it provoke anxiety. And this anxiety is distressing things to the individual. So the exposure should be graduated, repeated, and prolonged. Practice tasks should be clearly specified. So we have to identify all things that are avoided in order to control them, to making a graded hierarchy, as we'll come later to talk about it. The more complex the phobia, the longer it will take to treatment. They said 8 sessions usually adequate and average, but it might listen or prolong. Before going to treatment in practice, we'll talk about assessment of patient with phobic disorder from the cognitive behavioral perspective. What is the aim? Our aim is here to determine the precise nature of phobia and suitability for the treatment, because not all people or all patients are suitable for treatment. Then to define the goals of treatment, target, to identify appropriate measure of phobic anxiety. The precise nature of phobia treatment suitability. We have to ask about, as patient, as ordinarily we ask in our clinic, all the important area related to the presenting complaint, concentrating on the physiological and behavioral and subjective symptoms and about reaction to them. Assess the severity of phobia. This is important in the progress of the success of the treatment. Detailed information about avoidance, because sometimes similar phobia may produce different pattern of avoidance. For example, spider phobic avoid cleaning out cupboards, while another, also spider phobic, is especially careful about cleaning under furniture. So we have, the reaction is totally different, but the phobia is the same. So we have to take in the consideration this issue. Maintaining factors. The important maintaining factor in this vicious circle, as I said, is avoidance. Then the cognitive factor, which have a major area to play, that's the thought about dangerousness of these phobic situations. And also another important maintaining factor, that concomitant anxiety or the affective disorder or personality disorder. Whether there are a reason why it seems more comfortable to live with the phobia than to struggle against it. This is have to be ascertained initially in the assessment. Then also you have to ask the patient about existing coping skills, whether he faced cognitive behavioral therapy, he practiced before or not. He might come across some form of it before any therapist before coming to us. And also to inquire about resources of the person itself or client itself. Hobbies, aspect of success in his life. This is source of pleasure, success, helpful relative friends, personal characteristic, that persistence, sense of humor. All this will aid on the conceptualization of the background of the patient you are dealing with. Suitability for treatment. Not all clients or patients suitable for treatment for cognitive behavioral therapy, mainly severely depressed patients. We have to treat depression before. Some other personality disorder. In spite of that, recently there is a lot of literature mentioning that cognitive behavioral therapy for personality disorder, but it is actually difficult. It will take longer time. And alcoholism and drug dependence is another problem. So most probably these have to be tackled before we start cognitive behavioral therapy of the specific phobic disorder.
What do you mean by alcoholic? Safir?
I mean patients having, yes, drug dependence or alcoholism.
And it influence their response to cognitive therapy, or what do you mean?
This will interfere actually because it will be associated with, will break the, it will, as we will come later to talk about what's the basis of cognitive behavioral therapy and relationship between the therapist and the client. So they cannot afford these. So they cannot interact. They have the hostility, aggressiveness, unpredictable things related to drug dependence or psychotic manifestation related to that. So we have to, finish from all these things before exclude these. Not totally exclusion.
Or rule out.
We can just rule out, yes, not to affect our strategy and treatment.
Or maybe they can be treated prior to.
Yes, that's why.
Yeah.
Treat all these original conditions, then we'll deal with the phobic situation. Determining the goals of treatment. As you all know, that goals of treatment is obvious, that we're having phobia of something. Our goal is to remove this fear from this situation or object. But it is important to discuss the patient's precise goal, as these may not correspond with those of the therapist. For example, patients may be expecting the impossible results, so we have to be clear from the start what the patient expectation about the treatment, about what the condition will be later on after therapy. Measuring phobias, graded hierarchies and behavioral tests. Graded hierarchies is an ordered list of phobic situations used to guide exposure. Each item on the list is rated by
consider this behavioral approach, yes, or cognitive approach? So we're talking about both approaches now?
Yes, both approaches.
Grading, okay.
We'll coming to mention later on that exposure itself having behavioral element and cognitive element itself. It is in the same section.
Ideas بتاعتهم يعني.
Yes. Originally it was only concerned with behavioral strategies, and the cognitive, what we consider now cognitive aspect, they were considered as non-specific factor or confounding other confounding factor. But later on, as I mentioned also, the cognitive aspect became clear, and the importance of these proved in recent scientific research. Graded hierarchies. As I mentioned, each item on the list is rated by whatever, 0 to 10 or 10 to 100 scale, according to the amount of anxiety produced or avoidance by the patient. It is easier in the theory than in the practice. Behavioral test, doing something that has been avoided and rating the amount of anxiety experienced at the time, as I mentioned also from 0 to 100 or whatever. They have advantage, these behavioral tests, of that anticipatory anxiety, anxiety during exposure, and total duration of symptoms can be measured separately when you have these behavioral tests. But they have this advantage that they may be therapeutic because of the exposure nature involved here. So we are using it as a measuring tool. So at the same time, it might be therapeutic because there is exposure element in this. Self-monitoring, a daily record of exposure practice and of the level of anxiety experience. Then measure of the cognitions. This is recently been attempted in 1987. For example, rating of the fear of negative evaluation, agoraphobic cognition questionnaire. Actually, they mentioned many questionnaire. I didn't get the source of any detail about this questionnaire. For example, patient asked to identify what he predicts will happen when entering a feared situation. Anxiety will reach, for example, 7 on 0 to 10 scale. Then he will say, I will not be able to stay there for 1 minute. So this is the cognitive aspect. Then test this prediction. This is his prediction. Test this prediction in action. Prediction tend to be exaggerated or even catastrophic. For example, when he will be in the hot seat or in the situation, real situation, he will say, no, not like that before, that initial prediction. He will say, I will collapse, I will go mad, I will panic, I will. So by these methods, we can see the comparison between initial prediction before entering the real field and what he said when he is in the situation.
And what that means in your view, Dr. Ahmed?
Pardon?
What that means in your view, yeah. And when he thinks about something, he exaggerates the idea, but when he is in real situation, it is not that exaggerated.
No, it is exaggerated more. When he is in calm, he will suspect, I might get anxiety. As I mentioned, 7 out of 0 to 10, I will get anxiety to that limit. This is his initial prediction. But when he enters the situation, he will reach maybe, he'll say, thousands. I will collapse, I will go mad. So this is the element of exaggeration is very obvious. We'll come to this point, which is distorted thinking or distorted assumption.
The other way.
Assumption.
I think it's the opposite.
Pardon?
I understood at the beginning it was the opposite.
كده أراها تاني. لأنه معناه هو أنت as you said in the beginning, he thinks worse, and when they are in the real situation.
No, not this one. Not this one. I will come to actually, I will repeat it. Patient asked to identify what he predict will happen when entering a feared situation.
Okay.
At the same time, he was calm.
And this is on questionnaire?
Yes.
Yeah.
Oh.
Anxiety will reach 7 on 0 to 10 scale, for example.
Okay.
It will not, what he thought, he was predicting in his thought that I will not be able to stay there for 1 minute. This is my prediction.
Yep.
But when we test this prediction in the real situation, the prediction tend to be exaggerated or even catastrophic. For example, I will collapse, I will go mad. I will go mad. These, no, what we are taking the thought, what is running in his mind. Cognition. We are dealing with cognitive aspect now. So this is give us the importance of the cognitive aspect and thoughts, what our prediction and our
reaction.
Yes, before and during the. We'll come to these in detail in the treatment and practice. I mean, the bias is affecting the past, present, future.
Well, somehow we understand about the anxious people. Usually, their way of thinking is more catastrophic.
Yes, sure.
By the meaning that the will is.
And it is more catastrophic when it is in real situation.
Right. You think worse than you are, than the facts that are really in reality.
As you
Which is basic.
Yeah,
but now he is
more fearful.
مدة قد ايه حيكون مستدعي يعني حيزيد عنده؟
according to the situation, according to the yes, sure. And this is we use it in this is based of exposure. We want to anxiety to be then trying to teach or the client how to control anxiety, and this is we can use it as a beneficial tool regarding anxiety. Later on, we'll talk about it also. These predictions likely to be inaccurate, and so the effects of identifying and disconfirming them can be quite dramatic. Thereafter, there are standardized rating scales, for example, field questionnaire by Marks and Matthews, field survey schedule by Wolby.
طبعا ده مهم الفير سيرفي لانه مترجم للعربي ومستخدم.
You have the
الفير انفنتوري ده برضه من مزاياه يعني.
Measure of social evaluative anxiety by Watson. Mobility inventory for agoraphobia. Or this example of these questionnaires.
ترجموها الحاجات دي.
Treatment in practice. Introducing treatment, it is important to explain the model using the patient's individual symptoms to illustrate how vicious circle maintains symptoms, as we saw it in the diagram. The self-help rationale of treatment have to be obvious from the start. It constitutes from a treatment session plus homework assignment. The main job of the therapist is to advise the patient how to overcome the phobias, not to provide the treatment passively. Encouragement should be given readily. When we come to the graded exposure, a lot of elements actually here. To start with, devising practice task according to the condition. If the specific phobia, if it's a specific phobia, any means of communication can be used based of practice. I mean, talking about that thing or listening to or viewing things. If it's social phobia, identify factors which moderate the level of anxiety experienced according to the number of the people, their age, the sex, degree of authority, formality of the situation. You have to take all these factors into consideration to assess, to build up graded hierarchy. Phobias are less similar than their definition would suggest, and social phobic probably vary most. Sometimes the situations that the patient avoid appear to be unconnected. So how are we going to make a hierarchy? If it's if the fear is to many things appears to be unconnected. So we have to search for a theme that connects all these things. It's better to put it in under one hierarchy. For example, a patient has fear of speaking on telephone. Whether to build a separate hierarchy for each situation or this same one, we have to search for themes having common issues between all these situations.
وزي نحددها البراكتس دي احمد.
So after evaluation of all these factors related, for example, the social phobias, he's having fear of talking in front of the boss. At the same time, he's having fear of talking at phone. So, what's the thought about behind these things? Is it he's feeling that he's rejected? If it's that the issue, so the common theme it will be rejection. If it's no, he's having
authority, anxiety.
Yes, that's maybe a different issue. Or if there is any fear about losing control while talking in conversation. So, according to the assessment, yes. Breaking tasks down into smaller steps. This is helpful in building up hierarchy. Encouraging patients to search for opportunity to approach instead of avoidance, help them to adopt an ever-ready attitude. And this is example of hierarchy for fear of heights. And this is the statement here, rating scale from 0 to 100. To start with, look over banister on upstairs landing, look through closed first floor window. Then the scale will get
lean out of the floor window.
Lean out of first floor window, as above at friend's house, not your own house, plus second floor windows. this from 10 to 20, for example. Look down from plate glass window in office up to 6th floor. Then look down from top of town escalator. Use step ladder to change light bulb in center of room, and etc. Till we reach the number 13 is eat a meal in post office tower. This is 100% or 100 score in the rating scale. Some ways of devising variety of tasks relevant to this hierarchy, working on stairs and windows in increasingly unfamiliar places. So we have to modify this hierarchy according to our assessment and the situation of the patient. Sometimes we need to explore more, or sometimes we need to make it shorter if it's a mild severity and not a too wide range of stimuli. So it will depend also on the assessment of the patient. Then we'll come to the second point, conforming to the guideline of exposure. But sometimes, as I mentioned, there is guideline of exposure, it have to be graduated, prolonged, and repeated. But sometimes there is difficulties. For example, tasks cannot always be clearly specified in advance, repeated or graduated, because phobic situations are variable and unpredictable. For example, if there is one client having fear of dog, for example, we cannot guarantee that if a big dog will come across the street. So there is some difficulties. So what you are going to do, actually, it is helpful to stick less strictly to hierarchy and modify according to the situation, and to practice a variety of tasks covering a range of difficulty in the same week, or to analyze the situation into its smaller tasks or constituent parts. Another example of difficulties that many situations can't be prolonged. We need these. We need the time actually for anxiety to develop, then the patient, the client to control. But sometimes we have no opportunity. The situation will be very short. For example, signing a check in the public. Such tasks appear to be useful exposure tasks actually, and here the cognitive therapy having its emphasis actually. Another example of difficulties in applying the exposure, that disengagement, the patient or client in the situation itself, but he is not, he's in the situation by his body, but not by his mind. I mean, a kind of absence of mind. He's not thinking about this fear object. This is also obstacle in the exposure, because our aim is to develop anxiety to that thing, and then to mask this, to have control over the situation and decrease anxiety. Many phobic patients claim that they have already tried their one version of exposure without success. One possible reason is that they were not fully involved in the things they were doing. Therefore, patients should be alerted to this and told to make sure that they think about what they are doing when they are in practice. Method of applying exposure, real-life exposure. It can be useful to accompany patient initially during exposure to being within, then to phase out accompaniment before the termination of the therapeutic session. Treatment in group, actually I found very little source about cognitive behavioral therapy in groups. This is from the same book, that Cognitive Behavioral Therapy for Psychiatry. So I quoted also from comprehensive textbook of psychiatry. There is some they mention that in group therapy. Okay. Treatment in groups. Similarities between phobics also make them suitable for treatment in groups. Members of a group are often able to share ideas about coping and give each other much support and encouragement. Group exposure for agoraphobics, for example, joint expedition to town or shopping center, 3 group sessions per week, each for half a day, prove to be effective. Social phobics may also benefit from group treatment plus individually designed homework assignment.
In the الحالة دي, if we have a group, we have to have people who are complaining from the same phobia.
Yes.
Is better, yeah.
In spite of that, group therapy, they mentioned also, initially have to be individual sessions to introduce them. And first of all, we have to make sure that the patients or clients we have preparing for group suitable, and they have a great percentage of similarities, not to varieties of things, of fields, object, or situation. And then to start introducing them individually, first of all, about might be 2 or 3 sessions before entering to group. Then we'll start group according, either it is closed-ended or open-ended, according to the our aim of treatment, whether in the institution, large institution, or in the clinic, or then they mentioned something also. Group cognitive therapy, this is originally in 1889. Lenokov's work, they rely on his work mainly in group therapy, cognitive therapy. He mentioned that rationale is modification in the individual negative thinking, maladaptive assumption, and logical errors will relieve the symptoms. So we have the targeted rationale that establish norms of behavior that will increase adherence to the therapy's requirement through the development of group cohesion, discourage dropping out of the therapy, provide positive social reinforcement, provide source of peer support to facilitate acceptance and understanding of individual cognitive dysfunction. And they mentioned also regarding strategies and techniques to deal with any negative thought about group treatment, first of all, then to deal with, to anticipate negative response by other members. This is in details when coming to the group therapy and other clients coming to the group. They are mentioning another points, how to tackle these points from the start. But the basic, the backbone of cognitive behavioral therapy depends on 5 column procedure, that is situation, cognition, affect, alternative thoughts, new affect. Outside the cognitive therapy, they tend to know that if there is situation, there will be affect directly. But in cognitive therapy, they said no, there is something in between, that is cognition. What we anticipate, what we think, what our perception, how we perceive this situation, this will affect and will change our affect. And then that's why this is the base of therapy. You have to bring another logical and more positive thoughts, and alternative thoughts, and then we'll see the change in the effect.
So actually, you're talking about combining group therapy and individual therapy in a way that you can take the benefits from the group.
Actually, they mentioned
regards, like reinforcement coming from changing self-negative ideation or anything. But at the same time, the therapist has to do more tasks for the individual who.
Yes, actually, they mentioned it in under group cognitive therapy. Total
but
group.
At the beginning, you said that
have to be 2 sessions. Yes, individual.
So
have
the
to be
has to design
yes.
some specific
Yes, sure,
tasks
sure.
for each. Makes sense.
As we all know,
and you can consider the group pressure as a technique for changing cognition in a way.
And they actually work on depression more than the anxiety and emotional depression.
Especially in depressed cases, mainly they have a lot of negative thoughts. So when they exchange it with the group, usually they get some good responses. So it does help a lot.
Another method of applying exposure, imaginary exposure, in some cases, for example, fear of flying. We cannot make him flying every now and then. So real life exposure and imaginary exposure should be combined whenever it's possible, but sometimes you cannot. So we have to sort of the imaginary exposure. Has to be directed by the therapist initially. Progressive muscular relaxation may be taught for this purpose if necessary, and to be done at home also half an hour later on after they master the technique. Cognitive aspect of treatment in general. counteracting general biases affecting the past, present, future. This is the work of cognitive therapy in phobic disorder. We have to identify these counteracting general biases. For example, that's affecting the past. It is easy to remember events which have particular significance, for example, being criticized in front of other people, or which were associated with a strong emotion. It is easier to remember these things more than the successful or helpful or nice things. It is also easy in any mood to remember events that occurred when one was previously in that particular mood. So simple phobia can dominate person life. For example, he is phobic for we'll take example the specific phobia. But in spite of that, these feared object coming maybe once weekly or once monthly, but the phobia will predominate the life of the individuals. Why? Because actually when he is in mood of anxious or afraid, or he will think and he will just remember that situation. Here the basis for cognition. Successful exposure may be thought of as normal behavior. Even if the client was succeeded in not to be fear, not to be anxious in one occasion, but he tend to forget this because they think that this is normal behavior. So this is not to be registered and not to be remembered and treated as a matter of course and not remembered. Once a patient is able to do something without thinking about it, the event may be overlooked. So at the end, he will remember the negative situation and he will remember the failure, the situation when he failed, and at the same time he will forget his succeeding events, undermine his success before. And this the bias maintain the problem-focused perspective of the patient. So you have to ask about any success and also asking the patient to write down their success. And the biases might affect the present. And two elements very important at the present time, that hypervigilance and misinterpretation, which is common in anxiety people. Hypervigilance. Anxious people have a relatively low threshold for perception of threat. So have to tackle this problem by exposure accompanied by associated relaxation. We can use distraction initially also.
What do you mean by hypervigilance?
Patients, he will, as if start a response. He will dramatize everything. He's ready, anything that's maybe normal for others, it will be threatening.
يعني التيقظ المبالغ فيه، يعني بيبقى متيقظ لأي حاجة سلبية أكتر من اللازم.
For example, as this one, fear of flying, when he just read the newspaper that there is one airplane get crashed in some, he will get, see, he forget all the news in the newspaper and just he concentrate on this.
في السوشيال فوبيا كتير قوي، يعني مجرد انه موجود في مجموعة وحد مثلا بص أو علق بقى منتبه جدا لردود الفعل بتاعت الآخرين. فده vigilant.
Yes, and this is also have cognitive basis. That is the we're coming to the distortion in the thinking and negative assumption.
طبعا, it is over perception يعني, cognitive, definitely.
Misinterpretation. Anxious people tend to interpret events in a threatening way, especially if the event is ambiguous. Interpretation should be, so we have to identify the interpretation and re-examine and find out an alternative to the patient or client. Biases might affect the future. Anxiety also biases predictions about the future so that threatening events seems more likely, and it also seems more likely that the threat will be serious. It may affect the patient attitude to treatment also. Example of cognitive distortion in anxious person, catastrophization, personalization, magnification and minimization, selective abstraction, arbitrary inference, overgeneralization. I think we talked already about this in the cognitive behavioral therapy of depression. A specific cognitive aspect of phobia, social phobia, as we all know that thought about negative evaluation, criticism, rejection, this is obvious. What about agoraphobia? Also, cognitive have a role there, especially mainly thought about collapsing or losing control. This is cognition. So the cognitive aspect having roots in any sort or any type of fears or phobias, and even in any behavior we are doing in our life. And also they mentioned some sort of exposure that occur ordinarily in the life, a sort of exposure that takes place during everyday life. Social phobics may expect others to be unfriendly, but if they smile at a stranger, they may receive a smile in return. This is sort of, exposure for social phobic, but they need to be identified and then re-evaluated again in context of a specific expectation to be beneficial to the patients and to gain something from it. Cognitive factor preventing engagement in treatment also. Cognitive factor may also retard change or even prevent the patient becoming engaged in the treatment at all. And they have, I forget to write it down, the cognitive model of anxiety. Actual situation, then there is perceived situation. So it is difference. There is difference between actual situation and perceived situation according to the individuals. Perceived situation, it might be leading to perceived threatening, in threatening way, or self-efficacy. In confrontation with feared object or any trouble or stressful events, it is beneficial to some individual, and also it is causing anxiety and fear in another individual. It will depend on their interpretation and what they're thinking about that event of what situation occurred.
Like an anxiety before exam.
Pardon?
Like an anxiety before exam. It is good,
if the patient
adjusting.
Yes, if the patient is react in safe way, he will be calm, and this reinforces success in coping with like this situation. But if his reaction was in danger, threatening, and he was anxious, so this will having a negative reinforcement and will make avoidance. The avoidance will increase the anxiety and increase the vigilance of threat. This will increase her perception to the any situation happen, and then he will start in vicious cycle. Additional useful method can be used in cognitive behavioral therapy of phobic disorder. Technique for controlling anxiety: relaxation, distraction, identifying thoughts, and finding alternatives. Relaxation as this controlling anxiety, to have to be sure that this is only controlling, not abolishing. التحكم في القلق وليس استبعاده تماما. Relaxation, progressive muscular relaxation or applied relaxation in the situation itself, it is helpful in most of cases. The exception is blood injury phobia. Blood injury phobia is the exception in this matter, because the pathophysiology is different actually. Because in blood injury phobia, the blood pressure and will be fall down, will be lowered, and the heart rate will be lowered. So if we're going to make relaxation, it will accentuate the problem. This is the only exception. Blood injury phobia. Blood injury phobia, the client having fear when he is seeing blood, or somebody injured and blood is coming out. There is initial, yes, because initially there is a rapid increment in heart rate for a few seconds, followed by reduction in heart rate and blood pressure, and he will faint and collapse. And this is biologic and by physiology also. It is cannot be treated by relaxation. It is the opposite. That is applied tension. So we in this sort of phobia, we are going to use applied tension. That they teach the person or client to how to make his muscle tension, the opposite of muscle relaxation, and then just return back to normal.
More vigilant, yeah.
Yes, more, and just to start progressively from down till the head, just to make the head muscle tense. in this specific situation, in blood injury. Distraction.
I wonder also if they can use it for diabetes زي الحالات اللي بيحصل لهم إغماء في حالات
الهايبوغلايسيميك.
جمال الفير برضو اللي بيجي منها يعني بأنتي ريلاكسيشن بقى في الحالات دي.
The opposite of it is.
Very interesting idea دي.
Distraction, it is just you have to know also distraction not from the field object or situation, but from the symptom of the anxiety, not to perpetuate the anxiety itself. This is useful.
بس هل نعتبر الأنتي ريلاكسيشن هنا close to assertiveness training؟ يعني بنقول المريض انتبه وتيقظ لما نشوف يعني كأننا بندرب قدرته على الاسيرتيفنس الحقيقة.
Yes, this also here we have cognitive basis that
definitely.
is a certain assertiveness and his thoughts about what he's going to do, and also there is behavior that is relaxing. He's relaxing. He's
Attentive.
Attentive and making his muscle tension.
And he has to be very skillful in self-monitoring in a way to observe the internal clock بتاعته.
واسيرتيف في مواجهة الخطر يعني مواجهة مصدر الخوف.
He observes السيلف توك هي cognition.
ABC theories. Identifying thoughts and finding alternative, as I mentioned, this is the basic work of cognitive therapy. They have additional behavioral technique. We can use it also in combined with these role-playing, rehearsal, modeling, also proved to be effective. Role-playing more often in the treatment of social phobia. Rehearsal, it is a way of preparing for exposure. Modeling is most effective when the model exhibit and overcome anxiety in front of the client or group. Also, another additional useful method, or anxiolytic medication. Beneficial effects of exposure may be attenuated with anxiolytic. Nevertheless, there are times when it can be helpful. It is better not to use it because
during the behavior treatment.
Yes, it is better not to use it because it will counteract the aim of exposure. We want the anxiety and we want the client to master it. So this will abolish the anxiety symptoms and it will attenuate the efficacy of the exposure. But sometimes there is a situation we can use it temporarily also because there is a fear of addiction or long-term therapy. Complicating factor in the treatment as I mentioned before, this is I mentioned this factor in the suitability for the treatment. That is, if there is any generalized anxiety disorder or depressive disorder, have to be treated initially. And also there is cognitive behavioral therapies for this disorder. But in case of severe depression or personality disorder, drug dependence, alcoholism, we have to tackle these issues before we start cognitive behavioral therapy for disorder. Drug dependence and alcoholism, the statistics show that 7% of agoraphobics and 20% of social phobics are in drug dependence. And most of the drug dependence, we have to take this in consideration also, our minor tranquilizer we are using here. This is a great problem in these categories group. Anxiety people or phobic, this is a high rank in the dangerousness of they are very liable to drug addiction from these benzodiazepine. 50% of agoraphobics have history of alcohol intake to control the symptoms, not social drinking, no, just for the sake of controlling the symptoms.
Which again it is cognition, because they turn to drugs or to alcohol
yes, just to relieve them, just to abolish
symptoms of anxiety.
General points here, the understanding of the rationale and treatment model by the patient is very important. Whether symptoms can be attributed to anxiety, we have to sort it out initially and to explain to the patient. This is nothing to relate to any dangerous situation. This is a manifestation of anxiety. When you control the anxiety, everything will be okay. Look for evidence that exposure has beneficial effect and identify the basis. This will improve the efficacy and the result of cognitive behavioral therapy. Maintenance of change, very important. This is advantage over the pharmacotherapy because pharmacotherapy have the short-term effect on the symptoms we have. But here in cognitive behavioral therapy, the benefit will be long-standing. Will provide the basis, and because it's restructuring the cognition of the patient, so he will get benefit later on. Phobias can be reduced by approaching rather than avoiding the phobic object or situation. The active self-help rationale and the emphasis on the independent homework strongly suggest that change results from the patient's own work. Expectation for the future should always be discussed. Relapses are more likely at a time of stress, and it may be unrealistic to expect a phobia-free future in some cases. You have to be frank from the start. And they also advise some blueprint how to handle future difficulties. And this is an example of this blueprint. Don't shy away from doing things that are difficult. Do them quickly before you have time to start worrying again. Remember how many times you had to visit the post office before you felt okay. Now even the shops in town are okay. Do the relaxation exercise properly once a month as a reminder. Don't get bogged down in the horror of it all. It's more encouraging to think about the progress I have made before and what to do next. Write down the steps. Look back at the old record sheets. They show which order I did things in before and how much practice I had to do before it get easier. Go into supermarket alone sometimes. Don't always go with the family, even if it's more convenient to do so. Plan to go to all the school concretes next term. Concert next term. Breathe slowly when you feel bad. Watch out for thinking the worst will happen. It hasn't happened yet. And this is also regarding the number 8. It is strongly related to the somatic manifestation, because also breathing and getting carbon dioxide changes, and then all the anxieties related to what happened actually from this over-breathing. If things get difficult again, remember setbacks happen to everyone. You can't get through life without having some bad times. Work out how to practice in steps. Write the steps down, and make sure you tackle them one by one. Write down how you felt each time. Practice every day. There is no need to try to run before you can walk. Don't bottle it up. Talk to the family about what's happening.
ده طبعا example بس مرتبط بسبيسيفيك cases of phobia, right? اللي هو الخوف من الشوبينج وخوف من الأماكن الأجورة.
This is just an example of alternative treatment. We have pharmacotherapy and psychoanalysis or psychodynamic therapy. Regarding pharmacotherapy, anxiolytic and antidepressants are commonly used. It is helpful in short term, as I mentioned, but neither of them appear to produce stable long-term gains unless combined with exposure.
يعني في الجرأة انك تقول الكلام ده قدام psychiatrist, huh?
And this is from the psychiatric book.
قولها لهم بقى.
That's why I mentioned earlier. You have to be, open-minded to get benefit from what the scientific research gave us. So, and it is not difficult actually. Just to, as a sort of cognitive therapy for us before, just to, if we believe in that, so we can change later on. Beta blockers, commonly used for, especially for performance anxiety, but also this is symptomatic and for short term only. It can have no any long term benefit. Psychoanalysis and psychodynamic therapy, going to the past and digging in the history, if there is any sexual conflict, any problem in relationship in early childhood, are not effective in reducing avoidance behavior.
It's not delayed, really.
Like they mentioned also one example, the client went already to one of the psychoanalytic oriented therapists. He mentioned this is related to your difficulty in childhood and there's conflict and that. He was asking the cognitive behavioral therapist, what about that? He said, I have no idea.
I have no comment.
I like you. I not believe in this.
Adibas complex, yeah.
What about the effectiveness of exposure? Exposure-based treatment for phobias have been remarkably successful. This is from many, I quoted from the many literature. Yes, literature. More generalized benefit, and also they give more generalized benefit, for example, improvement in relationship, enhanced self-confidence. The exposure works, and that the effect are not simply due to non-specific factor as it was thought previously. In some cases, the effects can be potentiated by adding anxiety management or cognitive procedure, and that improvement is maintained for many years. Prolonged exposure is more effective than brief exposure. Exposure has cognitive as well as behavioral effect. The last statement in this presentation today, that the message I want to give to reach any colleague here, that cognitive therapies are sufficiently well developed, and the theories upon which they are based are sufficiently well worked out to provide greatly improved structure for these aspects of treatment. Nevertheless, the simplicity of the theory should not tempt the therapist into working mechanistically or suggest to them that therapy will be easy. No two people are even exactly the same, and working with phobic patients require much creativity. Because these treatments have high chance of being successful, it is both rewarding and interesting. Thank you.
Thank you. Very interesting. يعني استفدنا منك حاجات جديدة النهاردة كتير يعني.
للأسف يا دكتور كنت مش الأساس.
أنت معاك حاجة هتعرفها؟
بسم الله الرحمن الرحيم. And we're going to talk about for the next coming 15 or 20 minutes about some points in neuropsychiatric comorbidity of mental retardation. I will skip some points because of time. To start with, vulnerability of retarded person to mental disorder. What's the cause behind this, and what is the mechanism? They said many factors actually combined together. Sorry for the slide, it's not so obvious. Conflict between the expected self-image from the other individuals and from the population around the mental retarded and the real self-image. Dependency on the caregivers, on others in their life. This accentuates or may be a good factor in increasing vulnerability to mental disorder. Then communication difficulties. Actually, this also increases the vulnerability of mental retarded to mental disorder. Low self-esteem, associated handicap, mainly neurological disorder, also increase the vulnerability to mental disorder. Brain pathology may predispose one to an organic mental disorder. Epidemiology of mental disorder in retarded person. There have been many studies over the last few years, but actually it have inconsistent design and methodology and different results. But the prevalence in general range from 30 to 60%. This is prevalence of psychiatric morbidity in mental retarded patients.
النورمال population كامل.
Pardon?
النورمال population عشان تعمل كنترول يعني. ده في المنتال ريتارد 30 60.
If you can take any in the psychiatric specific, we'll come to that in specific diagnostic.
المهم ان دي much higher than the normal population.
In the study of االاول by Rata, they mentioned 30% of retarded children were rated as disturbed by their parents, and 42% of retarded children were rated as disturbed by their teacher, and the rate rising to the 50% among moderate to severely retarded children.
ده الاستدي ده اتعمل في ايل اوف وايت، يعني هو طبعا راتر ده مشهور، يعني هيز موست فيموس child psychiatrist in the world مش in England. فهو اللي عمل استدي في الايل اوف وايت، ودي جزيره محدوده يعني في هو في المنش، واخذ الكوتشنير من البيرنتس ومن التيتشرز، فوجد النسب دي اللي هو بيقولها.
Mental retarded children exhibited the same range of disturbance as children with normal IQ, but in addition, 3 disorders were much more frequent in this population. That are childhood autism, hyperkinetic disorder, severe stereotype movement disorder, and also self-injurious behavior and PICA were also frequent. We'll come to detail of these common diagnostic entity later on.
عدهم تاني بقى يا دكتور أحمد، لأن هم دول لو طلعتوا بالموضوع النهارده ال5 دول هيبقوا كويس. اللي هو
childhood autism, hyperactivity, and severe stereotype movement disorder, self-injurious and self-stimulation behavior, and also PICA can be added.
وهم نفسهم مع بعض ممكن يتم النجاح يعني.
ما كده ممكن يحصلوا مع بعض.
Etiology. If we come to the etiology varies according to whether if it's mild, retarded, or moderate or severe. In mild mental retardation, there is interaction of many factors in causation of mental disorder in mental retarded people. The most important factors that adverse temperamental characteristics, specific learning disorder associated with these mental retarded people, family psychopathology, limited parental capacity for